Hi, good evening, everyone, and welcome to this session for our residents and fellows. Our webinar for today is going to focus on posture, prehab, and performance. And we are all about mastering surgical ergonomics. We have a great panel and a list of speakers to present today. Starting us off, we have Dr. Nisha Narula. And then we'll see how it's finally working. And then followed by Dr. Edward Auyang, Harry Wong, Mary Kate Bryant, and to finish off for the evening is going to be Dr. Talar Tejirian. Uh, and so our first speaker for tonight is Dr. Nisha Narula. Dr. Narula is an assistant professor in general surgery at Rutgers, New Jersey Medical School in the Department of Surgery and an attending at the University Hospital. Her talk is going to focus on significance. Just as a reminder, for those who are not yet members, please sign up to join any of these SAGES member categories that are listed here. Obviously, for the residents and fellows, you join at that level, and we look forward to having you as active members. For those who are practicing use in Canada, there's also for in Canada or for other countries, there are also separate memberships. And also, last but not least, a quick plug for next year's meeting at Tampa. We look forward to seeing you from March 25 to 28. And with that, we're going to start off with Dr. Narula.
Well, thank you very much for the introduction and to everyone for having me on this panel with a great group. So I'm gonna briefly do an introduction about ergonomics and talk about the significance of surgical ergonomics as it pertains especially for trainees, which I think kind of boils down to why should you as a trainee care about this topic? So I'm going to go over a definition of surgical ergonomics, some of the short and long-term effects of poor ergonomics, and then how this is particularly relevant for you as a trainee specifically. So what is surgical ergonomics? So ergonomics is a true scientific discipline. It's focused on understanding workers and the optimal environment for workers. The applied aspect of ergonomics focuses on designing an environment that fits the needs of the individual worker as well as the team. And it's a multidisciplinary field. It pertains not just to surgery or medicine, but to any workplace environment. Surgical ergonomics specifically, and mostly we're going to talk about the operating room since that's what makes us unique. So surgical ergonomics focuses on the design of an operating room environment and how that can be made to fit the surgeon and the surgical team. It's divided up into two broad components, physical and cognitive. Physical ergonomics is pretty intuitive. It's kind of the physical part of all of this, which includes things like operating room layout, equipment design, and the surgeon's posture, surgeon's technique, although it also applies to others in the operating room. Cognitive ergonomics is the cognitive component of this, a little bit less intuitive, but it includes things such as mental resources, mental processes, things like memory, sensory response,
We
perception,
did.
managing information
Yeah.
display, decision-making support. You can also, some aspects of it also include things like distractions or mental load. So you may be thinking, well, this all sounds great. I would love an environment designed for me rather than trying to work myself into a not ideal environment. But how do you have the time? You have so many other things you have to learn about patient care, learning how to operate. You might have research or quality improvement projects. You're learning how to teach, mentor, be a leader. You might have fellowship applications, job applications. You have a personal life. Ergonomics seems sort of the least of all your worries. Well, I would argue that it's a very important part actually of taking care of yourself, and that includes your surgical self at work, but also your life outside of work, your non-surgical self, if you will. I think the analogy to making it sort of similar to eating right and exercising is probably fair. It's the type of thing that it's hard to make time for. We are all very busy, have multiple competing interests. But in both the short and the long term, it's things that really affect your health and your livelihood. So, that being said, I do think it's easier said than done. But here's some of the data for why you should really try to make this one of your priorities and something that you want to learn about. So most surgeons have pain due to operating. It varies depending on the study, but anywhere from 68 to 97% of surgeons have pain due to operating. So that's general surgery subspecialties like colorectal, surg-onc, endocrine, as well as the surgical subspecialties, ENT, plastic surgery, orthopedic surgery, neurosurgery. Every specialty has pain and in large numbers. It affects basically all areas: back, neck, arms, shoulders, hands, legs. And in addition to surgeons experiencing pain, we experience physical fatigue, stiffness, numbness, weakness. Depending on the modality you're using, different areas are reported to be more painful. So, open surgery, the lower back is reported to be the most painful in studies. Laparoscopic surgery, shoulders. Robotic surgery, the neck, which you may have anecdotally also found as well. And importantly, these symptoms of pain start early. In a study of PGY1 residents, 55%, so just over half, reported having pain due to operating. There may also be some disparities. So female residents in one study had more pain and fatigue than male residents. Unfortunately, and this study is a little bit older now, it's about 5 years old, but in that study, only 1.5% of residencies provided formal training in ergonomics, and more, about 25%, had some sort of informal training, although this could have been something as casual as just, a conversation in the hallway. So you are a little bit on your own in some ways, although I think that's changing with more resources and more attention paid to this. Okay, so fine. You agree that you have pain after you operate, but so what? You can handle the pain. It's just part of life, part of surgery, whatever. Well, I would disagree with that. I think pain itself is a problem, but other than pain, there are other problems that arise from potential poor ergonomics, and these have greater consequences. So they affect fewer numbers of surgeons, but they have long-reaching consequences. So poor ergonomics can potentially lead to musculoskeletal disorders and injuries, and these can be career-ending or lifestyle-changing, not insignificant. Um, so injuries have led to surgeons taking a leave of absence. And in some studies, that was anywhere 26 to 30% of injured surgeons. Surgeons have had to modify or restrict their practice, change what kind of cases they do, for instance, take an early, unplanned retirement, or get treatment that are significant, surgery or narcotics, which range depending on the type of surgery and study, but 20 to 83%. So these, I would say, are really not insignificant problems that can result from poor ergonomics. In addition to work, 59% of surgeons in one study reported that pain affected their life outside of work, and that study included multiple subspecialties. Um, so not only is there pain and injuries, this affects life outside of work. And in addition to this, there may be some effect on the surgical pipeline. So in one study where medical students who were interested in surgery and then changed their minds to go into something else, when they were asked what changed their mind, 36% answered that it was the physical demands of the field, which doesn't only include ergonomics, but that may be one aspect of why people may choose not to go into surgery. I think there are other things that, to my knowledge, are not well studied yet, but there may be an effect on burnout, on wellness, on patient care, either individual patients or ability to take care of patients for longer, and then effects on teaching. So, what's causing the pain and injuries? It's thought to be due to multiple repetitive motions that we do in surgery, as well as non-ergonomic postures, especially those that are maintained for long periods of time. So the idea is that by optimizing our ergonomics, we should be able to improve them to reduce pain, reduce injury, reduce disability. Some of the barriers include lack of knowledge. Again, we're not necessarily, or historically, we haven't been taught about ergonomics. And so there's a general lack of knowledge, which again, I think is changing for the better. And there's a lack of support. Administration, nursing, anesthesia, no one's that well educated. So it's hard to generate that support and some of the resources to optimize our ergonomics. So, why is this especially relevant for you as a trainee? Well, one factor is you're earlier in your career. You have a lot of room to learn, a lot of time, at least in years, to learn, and you have time to develop good techniques before you adopt bad ergonomic postures, bad ergonomic habits. And importantly, you want to be able to prevent an injury before it happens. So you're in the right spot for that. I also think you may have more say and more input than you think. As long as you're polite about it, you can make some suggestions when you're in the operating room, or even make little adjustments, like getting the step stool, adjusting the monitors, or speaking up. I think many people may be more amenable than you may think because we all, or most people in the studies, suffer from some sort of pain or discomfort. And then if you really want to get involved, you can also advance the field for yourself and for others. Ultimately, though, I think the most important thing about this is that this is for you to protect yourself. You want to be able to know about good ergonomics to protect yourself physically, take care of yourself cognitively, and protect yourself financially. And I think these are all kind of interrelated. Optimizing ergonomics really can have a big effect on your surgical life and your life outside of surgery, as well as your livelihood. So it obviously affects you while you're operating. It may have effects on patient care. It may affect you outside of work. And then if you do want to get more involved, you can teach others about it. You can get involved in leadership or quality improvement projects or research projects. So I think there's a lot of potential, especially if you're interested in optimizing ergonomics and advancing the field. So I think we're doing questions at the end. This is my email in case anyone wants to reach out. And here's a list of references I used for this talk.
Wonderful. Thank you so much, Nisha. That was great. And yes, we will do questions at the end, but appreciate that great talk. So next up, we have Dr. Edward Auyang. Dr. Auyang is a professor, chief of the Division of General and Gastrointestinal Surgery, and the vice chair of clinical affairs at the University of New Mexico, as well as our resident whiskey guy. And he's going to talk to us about optimizing ergonomics in the OR and the endoscopy suite. Throw it to you, Dr. Auyang.
Thank you for that introduction, Dr. Keller. Good afternoon, evening, morning to all of our guests, depending on, I guess, where you are throughout the planet. It's my pleasure to give a little talk on optimizing ergonomics in the OR and endoscopy suite. Let's see here. These are my disclosures. My consultant disclosures are not relevant to this talk. I do like to mention that I do have formal training in biomechanics and ergonomics. I took a non-traditional pathway to med school, if you will. I was a biomedical engineering major in college, and I did my master's in environmental and occupational health, specifically focusing on biomechanics and ergonomics. And part of that actually taught me how to become an OSHA inspector. But realizing that my career was headed in a different direction, of course, I ended up in medical school and going into general surgery. But I actually do have formal training, so this is not just kind of pulling things out or pure research based. We were actually doing health hazard evaluations in my master's program to look at some of these things that we're now talking about, and it's extremely relevant to what we do in surgery. So application of ergonomics is a massive subject. Again, I spent 2 years studying that. So in the 20 minutes that I have, I'll try to just scratch the surface. And ultimately, from a practical standpoint, I'll give you 3 kind of primary takeaway applications of ergonomics they can institute immediately in your own workspace. So instead of going through all the things going from instrumentation design, et cetera, we will find 3 things that you can do in your operating room, whether you're doing open laparoscopic or endoscopic procedures, and how you can apply those immediately. So first takeaway, how can you, modification of your workstation height. So this is a picture from actually one of my ergonomics textbooks that I used in grad school. When you're designing workstations for factories, for people who are doing repetitive types of activities, there are several kind of key principles. So in an industrial workstation design, you have what they classify as light work, precise work, and heavy work. And whilst we consider surgery being precise work, there are certain sterility aspects of it that we cannot apply. So normally, if you're doing very precise work, you're having your workstation very close to your face, or bringing that workstation closer to you with things like loops, or in our case, frankly, laparoscopy and magnification. So I decided to say, well, we're really kind of in that lighter work area. We're not lifting 50 pounds of an engine block part or something like that repetitively. I'd say surgery is considered kind of within that light work, though you could argue that if you're doing a large open operation and somebody's retracting a large abdominal wall and lifting on those sorts of surfaces, that maybe that is kind of heavy work. So ultimately, when you design your workstation, it sort of depends on the amount of load you're putting on your upper extremities, and therefore adjusting the height to maximize the efficiency of your upper body muscles. So again, precise work should be actually quite close and should be above elbow level. But frankly, from a sterile field standpoint, that's not a possibility. So from a light work standpoint, really your workstation should be at or just a bit ideally below elbow height. You want it a little bit more than 90 degrees from that arm to upper arm angle. And then for heavy work, you actually want your workstation approximately 10 to 20 centimeters below elbow height. So how do you achieve proper workstation height in the operating room or the endoscopic suite? So there are 2 main things. You have your table height, so you can adjust where the patient is, and then you can adjust yourself. So here's a picture actually of one of my residents we're doing a lap chole on a patient with a BMI of like 55. This table only goes so far down, and based off of her height, you can actually see I've got double layer of steps there, so 2-step height. But I've also created a 2x2 platform such that if she steps back, she's not going to fall off of it. She steps to the side, she's not going to fall off. So really, if you're trying to identify where is the patient's working level, being approximately where the second arrow is, she has to elevate herself such that her elbows are slightly below horizon, slightly below that 90 degrees. So in order to do so, this table is as low as it can go. But despite that, she needs to be on a couple steps to raise her up. One of the secondary principles of workstation height is that you need to adjust the operating surface or operating height to the tallest person who's actively in the operative field. So in this picture, actually, this is my medical student who's about 6'2", and then the other person, this is the operative height. This is again a laparoscopic case. We've tried to adjust the table height for the student who's driving scope, and the other person is actually my chief resident who's on the steps. And depending on what your culture is at your institution, they may be like, no, it's adjusting to the attending or to the most senior person. Really, the most ergonomic thing is to adjust to the tallest person actively in the operative field. And I will say, I'll have to give credit to one of my mentors, Dr. Nat Soper. A lot of you know him as a former president of SAGES. He's currently the chair in Arizona. He was my chair in residency, and I'm a few inches taller than him. And I remember when I was doing cases in the ER with him, he actively told me, we need to adjust it to your height, because if you're the one who's actively participating in the operation, we need to have it to your level. We'd rather have you raise the table to your level than have you stoop over and cause back and neck fatigue. And he actually would get on steps if necessary to assist during those procedures. So part of it is a culture change. But at the same time, these are important things like Dr. Narula talked about a little bit earlier. So again, here we've adjusted the working surface to be at the level or slightly below elbow level for my resident, and then, I'm sorry, for my medical student who's significantly taller, and then we've had our resident get up on a step in order to make that appropriate. One of the main things I see frequently in my own colleagues' operating rooms is when they don't adjust the height properly, either the table can't go lower or they don't get up on steps, and they end up doing what I call riding the chopper. So if you look at the picture on the left here, that's undue strain to your deltoid and your shoulders. Your elbows should not be at shoulder level when you're doing surgery. That is going to cause repetitive stress disorders. It really needs to be below the elbow level. So I call this riding the chopper. So I walk into rooms in the OR and said, hey, you all need to stop riding the chopper. Either lower the table height or get up on some steps. Otherwise, you're going to be hurting at the end of the day. There's no question about that. If you're doing that multiple days a week for your career, you're going to end up needing orthopedic surgery. The same principles hold true for open surgery, and then the same principles hold true for robotics. Everybody talks about robotics being more ergonomic. Well, it really depends on how you set up your console. So, you need to be paying attention to where you have your hands. This is me at a DV5. You can see in the first picture here, if I'm working with my arms kind of in that riding the chopper position, you're going to get repetitive stress disorder on your wrist. You really need to check your elbow location and really, oops, sorry about that, backed up too far, and drop your hands down. Otherwise, you're going to be causing the stress disorders there. You're going to be causing undue stress in your elbow location, and you'll be putting undue stress on your back as well. So really pay attention to where the operating surface is and where your elbows are relative to it. Adjust it to the tallest person, and then everybody should not have issues getting up on steps. And again, nobody likes to be on single steps, so put them side by side. Again, I create full 2x2, 3x2 platforms of steps, sometimes single steps, sometimes double stacks, so that again, people aren't going to fall off of those. So takeaway number 2, I relate that to visual angles. So again, this is from my ergonomics book that I used. And when you're creating workstations in factories and in industry, you want your visual fields to be pretty much in front of you, not too much to the left or right, and also not significantly above eye level. And in fact, visual field should be at or below your horizon, about 10 to 15 degrees, and you should not need to rotate your head more than about 15 to 45 degrees. This picture here says that, hey, if you're going to be looking 45 degrees and beyond, that should be more like rare sorts of things. If you're doing things within your normal visual field, it should be within 15 degrees of straight ahead of you. So in laparoscopy, for the surgeon themselves, these are some of the things that I focus on, really placing monitors directly across from the operating surgeon, as well as making sure it is at or below eye level. So in the picture here on the left, you can see my resident is looking at a down angle, so about 10 to 15 degrees down angle. A lot of people are like, oh, this feels unnatural. Actually, stand there for a long period of time and tell me if you're looking upwards for that same duration, which puts more strain on your neck and back. That's all biomechanically proven. So again, 10 to 15 degrees down angle. I ask our anesthesiologist to watch the drape location, so make sure you're not causing contamination, but really allowing that natural position of the neck. Here again is one of my residents. She's got her, even though she's on steps to accommodate for the patient's height, she has got her monitor at a down angle from where she's looking to, again, take that strain off of her neck and back. Now, we need to start paying attention to also your assistants in the operating room too. This is our surgical tech. She's unfortunately having to look around the resident in order to see what is going on. So you need to actually pay attention not just to yourself and to your assistants, or not just to yourself, but also to your assistants in the operating room. Because if they have a more ergonomic working environment, they're actually probably going to enjoy working with you more as well. If you're looking from a robotic standpoint, same thing. It's like there are a lot of abilities to change various aspects of a console, but if you don't change them properly, you're actually going to give yourself repetitive stress disorder. So ergonomics is about awkward postures and strain for extended periods of time. So whether you're doing that standing or sitting, you can have ergonomics problems either way. So in this situation, this console, actually the headpiece of the console is too low and probably putting undue strain on the neck and back. That's below 20 to 30 degrees right there, down angle. Whereas in the picture to the right, it's more of that straight ahead to about 10 to 15 degrees down angle. So when you have the ability to set up your console for yourself, setting the elbow height, setting the depth of the instrumentation, setting the eyepiece level, set those, save your settings so you don't have to redo it every single time. But all these little things will make difference day after day. Again, we talk about assistance, and this is one of the things I see a lot in rooms where they're doing a lot of robotic surgery, is that the person at the console's got their console all set up, they've got their perfect chair, they've got their anti-slip mats, they've adjusted their elbow, they've adjusted their headpiece, but the assistants who are sitting around are having to look at these monitors that are placed in poor positions for them. So you see here, this is an assistant. They're trying to look at a monitor that's over top of the arms. And if you're maintaining this position for long periods of time, this is putting undue stress on the neck. The person who is sitting underneath that monitor is actually looking at the one on the tower. And you can see how high that monitor is on the tower. And that's what their visual angle is. So I associate this to you have your flat panel TV at home. A lot of people love to mount it above the fireplace. That is the worst place probably to mount it, unless you are literally laying flat or have a very steep recliner to lay on to keep your eye angle at an appropriate angle. Either that or you're standing full height on top of steps and looking directly across. So I keep my television monitor at home on a small 1 foot television stand. You shouldn't be putting these monitors at high angles. So to that end, here's a picture of one of our assistants. She's sitting there trying to watch, paying attention to the operation, swapping out instruments when necessary. But I walked into this operating room just the other day and I was like, hey, that monitor is awfully high for you. So I just went ahead and, because you can see that's what her visual angle there is, approximately 20 to 30 degrees above her horizon. I just went ahead and lowered that arm so it's at her eye level or slightly below. And immediately she's like, oh yeah, that's a lot more comfortable. She's not cursing the attending for making her, assist in this case. It makes it a much more ergonomic and biomechanically sound setup. Here's an example from endoscopy. Okay, your primary endoscopist is directly across from the monitor, which is great, slightly 0 to 15 degrees down angle. They've got the bed in a pretty good position. You can see the elbows are lower. What's the assistant doing? They're craning their neck completely around. So finding opportunities to use accessory monitors, things along those lines will really help out. And it's not just yourself, it's also your staff. And if you pay attention to that, that culture will develop. It's to the point now where my chief residents will actively say, hey, we need to lower the monitors. We actually check those before we even prep and drape patients. Find an advocate, find a champion within your group, and really start instituting these things. See, again, her angle is terrible. So third takeaway, I want to talk about surfaces. So anti-fatigue mats are not princess pads. Here's me, I kind of half jest, but I take a little anti-fatigue mat, put it under my legs. If I'm observing my colleagues doing procedures, you need to get over the culture that these are, for princes or princesses. These are really for your own well-being. So what are the values of using anti-fatigue mats? They help prevent slipping and increase grip, especially on wet surfaces. And that holds true if any of you have ended up in a major trauma laparotomy and blood is going everywhere. Like, you don't want to be slipping on the ground. And then ultimately, they do ease foot pain, leg pain, and lower back pain by having the cushioning. I mean, I wear my Air Jordans on top of everything else, but having that extra cushioning is really beneficial. This is a picture of one of my operating rooms. hey, I've got one laying flat on the ground on one side because it's going to suit my height appropriately. And then for the person who's assisting on the opposite side, they're going to need steps. I put an anti-fatigue mat on top of that. And you can see, again, I'm using a 2x2 platform here such that they won't fall if they step back. They've got some room to move laterally side to side. They're not confined to a little spot. Mats come in multiple sizes, of course, large. I will use multiple small mats and set them up all around the patient table themselves so that not only do myself, resident student, have access to them, but my surgical tech and the assistants, they are there standing just as long as you are, make their experience just as comfortable as yours. Again, here's that picture of my resident being up on the steps. Again, 2x2. I've got the mat on top. This is a commonplace. This is not a stage thing for my operating rooms. We really focus on this. And when the residents start believing in it and understanding how they feel after surgery, they end up telling the other attendings, why do you hurt after surgery? It feels good when I'm in Dr. Auyang's operating room, even if I'm doing a 4-hour redo paraesophageal, my neck and back and shoulders aren't hurting the same as they are when I'm in your room doing a 2-hour XYZ. So they're trying to help spread the culture as well. And I think that's really the best way to do it, is to kind of believe in it and experience it. For the steps, if you are standing on a single step, they do make small mats. And they're not expensive at all. The first time I went out and got them, I actually got them from like a Harbor Freight or a Home Depot. And then the hospital said, hey, you know what? We can actually buy these. I'm sure they're a bit more expensive because they're official OR equipment. But ultimately, you can find very cheap anti-fatigue mats. Amazon, again, any hardware store has them. When I talk about surfaces, it's not also about standing surfaces, but also about rolling surfaces. So one of the things that puts excess strain for folks who are doing robotic surgery is that if your chair is on wheels and things are rolling, you're having to use accessory muscle groups in order to make sure that your chairs aren't sliding back and things along those lines. So, if you have a chair that has locking wheels, that's great. I know people have even literally put straps connected to the console behind their chairs in order to prevent themselves from rolling back. But it's like, you can see, this is one of my colleagues, we're not as fancy at the University of New Mexico, so we don't have all these cool chairs. He's put a towel underneath there to prevent it from rolling so that he's not having to use accessory muscle groups, so his chair's not rolling back repetitively. So these are cheap things. They're towels and blankets in every operating room out there for the patients. You take an extra one, you put it down there, it helps provide slippage. So when you think about surfaces, it's the surfaces you're standing on, the surfaces that you're sitting on, and then ultimately, it can serve other purposes as well. So using these mats to help provide tripping hazards. Tripping hazards is an aspect of ergonomics. I remember when I would go to various industries and factories to actually do ergonomics evaluations of them, we would look for loose wires, loose cables. These are all things that affect your work environment. So really keeping those covered. Again, unfortunately here, hopefully they have enough that they're not just using them as wire covers, that they're using them for their own purposes as well. But it's a great way to prevent slip, trip, fall injuries, which is an aspect of ergonomics in your work environment. So ultimately, my 3 takeaways are, focus on your workstation height. It's very easy to do. You can raise and lower your tables. You can use steps if necessary. And you start at the very beginning of the case saying so. So like before you even prep and drape the patient, when you're walking up there, look at who else is going to be in the operative field and say, well, okay, so-and-so is the tallest person. We'll probably need to have the table set at this height. So I'm going to need a step, or maybe we need to get 8 steps in the room. I've requested whole stacks of steps. And frankly, even myself, I'm about 5'11". If I have a large, BMI 60 patient that I'm operating on, you can only lower the table so much. I will get up on steps myself to do things like lap colis or hiatals and things like that, because I don't want to be riding the chopper. Takeaway number 2, your visual angles. Again, try to have your monitors or your visual surface directly across from you. Deviate maybe 15 degrees in each direction, but you really shouldn't have to deviate more than that, and try to keep it at eye level or below. So even before I prep and drape the patient, I bring out my monitors. I make sure that I'm able to get those positions even before we prep and drape. I kind of mock up, I'm going to stand on the left in this case. where's the monitor supposed to be to maintain those straight angles based off my port placement. I set those things up even before we prep and drape the patient. And then finally, takeaway number 3, everybody should have access to anti-fatigue mats out there. If your hospital doesn't have them, they're very cheap. I mean, just as cheap as suture material. So they need to make a small investment. They do make a difference. And utilizing them for both floor surface as well as elevated surfaces. And again, consider other things that they're useful for. Again, here I put that, the riding the chopper person, but this person realized that's probably kind of ridiculous that my arms are up in that position. They actually created extensions so that their elbows are closer to 90 degrees, but they ergonomically modified their own chopper for their own well-being if they're riding for long periods of time. So, and again, this is the textbook that I referred to, but thank you so much. And again, if we're taking questions at the end, we'll save them for that time.
So hi, I'm Andrew Wright. I wasn't here right at the very beginning to introduce myself. I'm the chair of the Surgical Ergonomics Task Force for SAGES. I think we have like 4 minutes for questions before Dr. Wong's supposed to go. So Ed, maybe I can ask you a quick question about micro breaks in the OR, and is that something that you do? And can you touch on that a little bit?
Sure, absolutely. Yeah, I try to keep a mental track. I should probably actually put a timer about every 30 minutes into a case. I'll ask, and if it's a reasonable time, I actually ask people to just stop. Let's step back. I have people like jump up and down. I call it the Taylor Swift. I call it the shake it off. And everybody just kind of relaxes for a while, gets rid of your tunnel vision, move around even for 15 to 30 seconds, and you go back to it. So I try to do that about every 30 minutes or so. I keep kind of mental track by looking at the clock. I know there are probably some folks out there who actually set specific timers, but I definitely do that. And it's really beneficial when you have like long redo foregut cases. You're in there for, 3, 4, 5, 6 hours. Taking those micro breaks is huge.
Yeah, there's actually a nice set of stretches that you can do well scrubbed in as completely sterile. So there's a website called OR Stretch. And so if anybody's watching, you can look that up. And it's nice because I'll stop anytime there's a natural pause in the case. I don't set a timer myself, but when there's a natural pause, you're waiting for a staple load, you're waiting for something. It's a great time to do that. Awesome. And just as a reminder to the folks watching, please feel free to put your questions in the Q&A tab. And at the end, we're going to have a big panel discussion with all the questions and answers. So I'll go ahead and introduce our next speaker, Dr. Harry Wong, who's Assistant Professor of Surgery at Keck at University of Southern California. He has a background in kinesiology as an undergraduate and has had an interest in stretching. Speaking of the OR Stretch, Harry will probably touch on that. So he's very interested in promoting surgeon physical well-being and optimizing surgical ergonomics. So Dr. Wong.
All right. Thank you so much for this invitation to give this talk. Yes, and in fact, I will cover the Mayo Clinic OR stretches. So perfect transition into my talk. So the goal of my talk here is just to kind of give you guys some practical tips in how you can do these intraoperative micro breaks and stretching during surgery as well as between cases. Now, before I start, I just want to, I know some of the earlier speakers have already touched on the prevalence of musculoskeletal disorders among surgeons, but I really like this article that was published in JAMA Surgery. They sort of compared the 12-month prevalence estimates for work-related musculoskeletal pain among surgeons and compared that to other high-risk occupations. I thought it was really interesting that they found 65% of surgeons are having neck problems, 52 are having shoulder problems, and you compare that to a construction worker. We're using sort of same questionnaire. They have neck problem 32% of the time and 28% are having shoulder problems. So, the surgeons are having, more musculoskeletal issues compared to construction workers, which I thought was, kind of a profound thing. And this is a nice little video I was able to capture when I was visiting Japan last year. This was at a construction site in Tokyo. We're walking around and I just saw this and I was like, I have to record this. All right, you see these construction workers, they're like taking a break. It may be at the beginning of their shift or in the middle. They're, doing stretches and exercises. I thought that was pretty cool. So, if construction workers can make stretching breaks a priority for their workplace safety, why shouldn't we do the same in the operating room? And in terms of, interventions, when you notice you have pain, what's the first thing you tend to do? And that's usually to stretch. And there's actually been, studies and some data to support this, as Dr. Wright has alluded to. One of the earlier studies, one published in 2013, they looked at 16 different surgeons, and they had 20-second breaks every 20 minutes for 2-hour surgeries, and it was matched operations. They actually saw a statistically and clinical significance in reducing fatigue from the surgery. There was about 50% reduction in fatigue and body part discomfort. Another study in 2011 looked at 7 different surgeons, and they took 5-minute breaks every 30 minutes. Not only did they not notice increase in surgical duration, they also actually tested the stress hormones and alpha amylase in the surgeon's saliva and found that regular intraoperative breaks during laparoscopic surgery reduced markers of stress in the surgeons, potentially, optimizing performance. They also found that, the heart rate variability was also reduced with the breaks. Now, this is the paper or the group that Dr. Wright had mentioned. Mayo Clinic group had done this study looking at intraoperative micro breaks with targeted stretching to enhance surgeon physical function and mental focus. So they wanted to investigate the effect of intraoperative targeted stretching micro breaks on the experienced pain, fatigue, physical functions, and mental focus of the surgeons. They had a total of 66 participants from 4 different medical centers, and they were asked to rate pain, fatigue, physical, and mental performance using this validated scales during 2 operative days. And they noticed that majority of the participants that used the targeted micro breaks, microbreak with targeted stretching, perceived improvement in physical performance, 57% of those. And then there's 38% reported improved mental focus, and 87% said they would want to incorporate this into their operating room in the future. And most importantly, there was no increase in operating room time, which was important. This is some of the illustrations. There's the QR code of the website. You can go and actually find the video tutorial of how to do these OR stretches. They're designed that you can do while scrubbed in and sterile. And as part of the webinar today, I would love to invite everyone to wherever you are, try to stand up and follow along with this next video. And we're going to try to do these stretches together.
The base position for these activities is standing balanced, with your feet approximately shoulder width apart. Your hands are at the level of your belly button, with your fingers interlaced. Take a deep breath in, filling out your ribs. Keep your chest high as you breathe out. Shrug your shoulders up towards your ears, then back, pinching your shoulder blades together. Then lower them down, keeping your chest up. Bring your arms up to shoulder height with your palms facing your chest. Reach your hands forward as far as you can and follow them with your shoulders to reach further. Pinch your shoulder blades together as you return your hands to your chest. Turn your hands over with your palms facing away from your body and repeat the forward reach, following with your shoulders. Pinch your shoulder blades together as you return your hands to your chest. Return to the base position. Lift your face toward the ceiling and let your head drop back. Take a deep breath in, feeling the lengthening on the front of your neck and upper chest. Relax as you release your breath and return to the forward-facing base position. Tuck your chin to your chest, feeling lengthening in the back of your neck. Continue curling forward, feeling the lengthening down your thoracic spine. Return to the base position. Keeping your feet approximately shoulder width apart, take a short step forward with the right foot and lock your pelvis facing forward. Turn your head toward your forward foot, looking over your right shoulder, feeling the lengthening in the back of your neck. Continue rotating with your shoulders, feeling the lengthening down your spine. Return to facing forward. Side bend away from your forward foot, leading with your shoulder and curling your trunk to the left. Feel the lengthening along the right side of your torso. Return to facing forward. Switch to left foot forward while maintaining your feet approximately shoulder width apart and lock your pelvis facing forward. Turn your head toward your forward foot, looking over your left shoulder, feeling the lengthening of the back of your neck. Continue rotating to include your shoulders, feeling the lengthening down your spine. Return to facing forward. Side bend away from your forward foot, leading with your shoulder and curling your trunk to the right. Feel the lengthening along the left side of your torso. Return to facing forward. Return your feet to the base position. Pinch buttocks together like you are trying to hold a dollar bill between your cheeks. Take a deep breath as you lift your chest up toward the ceiling and gently arch your low back. You should not be bending backwards. Relax as you breathe out, returning to the base position. Renew the buttocks pinch and take a deep breath in. As you exhale, perform an abdominal crunch around your hands. You should not be bending forward as you perform the crunch. Return to base position. And finish with another deep breath in and out. The
All right.
base position.
So that was a nice little video, and you can actually, so that was a nice little video that shows the stretches you can do while you're in the OR, while you're scrubbed in and sterile. If you go to the Mayo Clinic website, actually they have a little timer. You can actually set, included with the link of the video and also a timer. You can actually set what the duration you want the timer to go off, and then it'll play the video to kind of help you guide through it. There's also a seated version of this, which, it's nice to actually have in the operating room. You can print these out, laminate them, just like have them in the OR available, or post them on the wall, but obviously get permission from your operating room administrators and staff. But this is actually something, right? We talked about having the bedside assistant for robotic cases are often sitting down, right? This also is a nice way for them to do some stretches while they're, assisting with the robotic case. And then more importantly, as surgeons, we know there's a lot of time we're just, hurry up and wait, sitting in pre-op and PACU, waiting for the next case to go, or, doing whatever. And they actually, also included these stretches you can do while you're sitting down, waiting for different cases, sitting at a computer. And some of these are also very helpful. So I'm going to play the video for this stretch as well. So if you can keep following along to try these exercises together.
This video is to guide you through a series of movements which have been selected to specifically address areas of your muscles, joints, and nerves. Throughout all activities, it's important for you to breathe freely, allowing air to flow in and out without restriction. Keep all motions gentle and smooth, without bouncing or adding additional force, such as using the other hand to increase movement. You will likely feel some tension as you approach the end of your available movement. This should feel like tension, not pain. Your available movement will likely be different than other people around you. Everyone is different, and you should avoid attempting to move beyond the sensation of tension. If one of the activities causes pain, stop and move on to the next one. The base position for these activities is sitting balanced on the front part of your chair with your feet approximately shoulder width apart, sitting as tall as you can. Extend your right leg out in front with your knee straight and your heel on the floor. Try to keep your ankle at 90 degrees throughout this activity. Keeping your knee straight, lean forward towards your knee, leading with your belly button. Feel the elongation in your hamstrings. Relax and return your right foot back to the base position. Repeat with the other leg. Remember to lean forward, leading with your belly button. Relax and return to the base position. Place your hands on your iliac crests with your fingertips toward your back. Take a deep breath, lifting your chest upward and gently arch your low back, using your fingers as a focal point for the arch. Perform an abdominal crunch as you exhale. Relax and return to the base position. Shrug your shoulders up toward your ears, then back, pinching your shoulder blades together. Then lower them down, keeping your chest up. Lift your face toward the ceiling and let your head drop back. Take a deep breath in and relax, releasing it. Return to the base position. Tuck your chin to your chest and curl forward, lengthening first the upper part of your neck and continue curling to lengthen your thoracic spine. Return to the base position. Turn your head, looking over your right shoulder. Continue rotating to include your shoulders, feeling the lengthening down your spine. Return to the base position. Turn your head, looking over your left shoulder. Continue rotating to include your shoulders, feeling the lengthening down your spine. Return to the base position. Cross your right leg over your left. Reach across with your left hand and hold your upper knee as you rotate your torso to the right. Relax and uncross your legs, returning to the base position. Cross your left leg over your right. Reach across with your right hand and hold your upper knee as you rotate your torso to the left. Relax and uncross your legs, returning to the base position. Reach your right arm out to the side and up over your head, placing the back of your hand on your head. Take a deep breath as you reach your right elbow toward the ceiling, side bending to the left. Relax and release your breath as you return to the base position with your arm at your side. Repeat for the left side, reaching out to the side and overhead, placing the back of your left hand on your head. Taking a deep breath as you reach your elbow toward the ceiling. Relax and return to the base position. If you are unable to place your hand on your head, place the back of your hand on the front of your shoulder and perform the side bending without stressing your shoulder. Begin with your right arm at your side and palms facing backward. Flex your right wrist by pointing your fingers behind you while keeping your elbows and fingers completely straight. Take a deep breath while reaching your right arm back as far as you can. Relax and return to the base position. Repeat with the left side, taking a deep breath while reaching back with your left arm. Relax and return to the base position. Begin with your arms at your side and your palms facing the floor, with your wrists extended and your fingers completely straight. Take a deep breath and push your hands away from your body, out in front of you, and then up toward the ceiling as far as you comfortably can while keeping the elbows and fingers straight. Continue pushing your hands away from your body as you lower your arms back to the base position, breathing out and relaxing. Return to base position and take a deep breath in and out.
All right. Hopefully everybody is stretched out at this point. But is stretching, like the micro brace is great, right? Stretching is awesome, but is stretching alone enough? Right? I think that's an important question because if you looked at a lot of the sports medicine or sports science literature, right, we know oftentimes stretching or, flexibility based training only gives you more sort of like temporary relief. It's really, you need to be adding on resistance type training or, really train your muscle groups that will actually help you prevent injury in the long run. And the idea is you want to really train the proper use of your larger muscle groups to help offset some of the force needed by the smaller muscle groups, right? We talked about surgery being sort of like very fine motor control work, right? So you want to really practice using your muscles, activating your proper muscle groups to help you maintain your posture, your balance, so that, it becomes an automatic process so that you can actually focus, your body can focus on the fine motor work that you are doing. And I think, we frequently talk about this concept, the surgeon athlete, right? Surgeons get compared to athletes, right? It's very much a physical occupation, right? We do a lot of work with our hands, with our bodies, right? And you want to think about what are the key components of any physical training, right? For someone who does physical work. So right, and you see flexibility is only very little part of, right? You also need stability, you need strength, you need endurance, balance. And the last part, recovery and regeneration, is also an important part. I know as surgical trainees, you are not always responsible. You don't always have, time on your side, right? There's only so many hours in the day. If you want to do all the things you need to do and take care of yourself, you don't always have time for that. But any little thing that you can do to help you maintain that is going to be helpful in the long run. And there was this article that was published in General Surgery News. Actually, the author is one of our speakers today in our webinar. But if you want to look up this article, there's some additional exercises, both kind of in terms of a prehab, rehab exercise you can do to help prevent injury in the long run. And I think Dr. Tejirian will probably talk more about, how you can take better care of yourself and improve your physical well-being so you can prevent injuries. And then lastly, this is just, the website and again, the QR code of the Mayo Clinic OR stretch, so you can have it readily accessible. Just bookmark it so you can actually use it next time you're in the operating room.
Great. Thank you so much, Dr. Wong. We really appreciate your insights here. And I definitely used your stretches in the operating room. Loved the session that you did at the annual meeting last year and hoping for more. So next, I am so pleased to introduce Dr. Mary Kate Bryant. Dr. Bryant is an assistant professor of surgery at the Medical University of South Carolina and the VA Medical Center in Charleston, South Carolina. She's especially interested in moral distress and work-related injuries. She's going to speak to us about cognitive ergonomics today.
Thank you so much, Dr. Keller. I am looking forward to sharing about this topic and hopefully sort of broadening the spectrum of ergonomics past just sort of what you think about into a very component of ergonomics, which is cognitive ergonomics. I have no disclosures. Today we'll touch on a brief overview of cognitive ergonomics. I'll discuss the nuts and bolts, cover the data, what we see in surgeons, and hopefully provide some practical tips. I think usually we think of ergonomics mostly as the physical ergonomics, how you interface with your work environment or the physical effort of completing a task. Dr. Narula introduced this concept of cognitive ergonomics, but this is really concerned with how mental processes impact your interactions with your work environment. So this includes everything from attention, working memory, executive function, which can impact decision-making, precision and perception. And in a nutshell, it's really our ability to pay attention to multiple things at once, which is what we do as surgeons, and figuring out where the limit is in that begins to impact the outcome of our performance. And I think as humans, we try to do a lot of things at once, especially in the operating room, as we've previously touched on. You are, constantly distracted. You're teaching, you're communicating with your team. There's environmental factors, there's patient factors. And this certainly isn't a new concept. I think our environment has become a bit more complicated, but as humans, our sympathetic response to stress is the same, whether you're on the battlefield or mid-lap chole when this happens, and all of your heart rates just went up, and our fight or flight response activates, and we have this increased spatial awareness and physical strength, but our higher order thinking and problem solving suffers when this happens, when our stress level goes up and we have no way to control that. And that's really the opposite of what we need in this situation. Not every day in the OR looks like this, thankfully, but I think we can prepare our minds to approach the stressful and often chaotic environment that we work in. I don't think any of us need a study to confirm how cognitively challenging our careers are, but nonetheless, this study table on the left there shows kind of how we compare as surgeons with the cognitive load of different professions, finding that surgeons have one of the highest cognitive load scores. There are certainly other measures that are used in a lot of ergonomic studies, such as the NASA Task Load Index, which is used to assess cognitive load and has even inspired a surgeon-specific measure called SURGE TLX, which showed higher load indices in surgeons over pilots, even during routine practice. Whether that's a routine case or a routine, flight schedule for a pilot, we're still seeing higher cognitive load scores. Heart rate variability is also a marker of cognitive load and used in many studies, and confirms that if you take the raw scores of, say, a vascular surgeon doing a AAA repair during clamp time and compare that to a pilot navigating an unfamiliar territory in unfavorable conditions, the scores are still worse for a surgeon. And there are many other biomeasures that people use in studies like EEG, eye tracking movements, a lot of wearable devices that we've been able to use to cognitively or to objectively measure our cognitive load in a performance setting. And I think they all confirm what we really already know about our day-to-day. The needed level of focus, concentration, and attention to detail is just much more sustained than a lot of other professions, both in the intensity and the duration and what we need, both in the operating room and outside. And I think this brings into the concept that I want to talk about, which is cognitive load theory, which I think is important for understanding what we can modify in our cognitive ergonomics. And this is comprised of three things: intrinsic load, which is the inherent difficulty of a task; the germane load, which has more to do with education, but essentially is how the task is taught. And then there's extraneous load, and this is kind of everything else. And I think there's a lot of things we can do to optimize our extraneous load. This is, the stuff like fatigue, disruptions, multitasking, our time pressures that we feel to do so many cases in a day, conflict and communication breakdowns that can happen in the operating room and outside. So the goal here in cognitive ergonomics is really to reduce our intrinsic load, and that may be through repetition, preparation, technical skill development, while also reducing our extraneous load. So minimizing all the things so we don't exceed our working executive functions. That's really our goal here with cognitive ergonomics. And I think as an example of this theory, this review paper looked at work that has been done on cognitive ergonomics and robotic surgery. And I think in the argument for better cognitive ergonomics on the robot, studies have shown improved intrinsic load with better physical ergonomics, which can lead room for a higher cognitive load. On the other hand, there are studies that would say that our extraneous load is increased in robotics with reduced situational awareness, with being further away from the patient, communication difficulties with, maybe being on the console in the corner of a room, and then also potentially an increase in intrinsic load with the need to control more instruments than we have hands for, limited visual fields, and even a lack of haptic feedback, which has been studied to potentially increase our intrinsic load in the robotic setting. So I think this gives a nice example of kind of how we can apply this theory to a concept in surgery and what we can change and what we sort of know increases our both intrinsic and extrinsic cognitive loads here. I think this also highlights what can happen over our career, which is that we, may have an improved intrinsic load for more experienced surgeons, but that also different surgeons can experience the same situation with different balances of intrinsic and extrinsic loads. And I think this is especially applicable to trainees, where a very straightforward case to a seasoned surgeon may feel very overwhelming cognitively to a trainee. So I think it's very, very important to understand not only what maybe your cognitive load is, but what you may find your trainees are dealing with also. And poor ergonomics is physical ergonomics is really this chain reaction that can lead to pain and injury and increased cognitive load, and then poor cognitive ergonomics. In fact, a systematic review actually showed an unoptimized environment, and specifically poor ergonomics intra-op has consistently ranked as a top 5 distractor in the OR. And this can obviously increase errors. And we see the rate of errors by a surgical team is increased linearly with increases in surgical flow disruptions. So people coming in and out of the room, constantly disrupting, what is going on at the operating room table. And we further see this with physical ergonomics or chronic pain actually being associated with negative cognitive abilities. So things like attention, working memory, concentration, and psychomotor speed. And this definitely can lead to increased physician burnout. And we've seen that in studies before, linking these things together. It's not just about us, though. And I think studies also find that our number of intraoperative errors correlates with increased disruptions in the operating room and our own fatigue. So not only are we suffering, but our patients can be suffering when we are not mentally present in the way that that we should be in dealing with the stress of our environment. So what can you do? So I think it's important to touch on cognitive training. And this really focuses on skill acquisitions to help with this mental load processing and hopefully allow you to have better problem solving, attentional stability, even better self-confidence and mental capacity, hopefully to decrease your mental load despite the fact you're in higher stress situations. There are several apps. I have some pictures of some of them on here that are based on cognitive training. The one up top that has the brain on it is an app called Impulse, which has the highest rating on the App Store. No promo here, but it's about $50 for a lifetime subscription. And instead of reaching for TikTok or Instagram, it'd be great to download one of these. Many of them have some free aspect to them. And this is something you can reach for instead of getting on social media or, you know, as a way to sort of increase your cognitive training and hopefully, you know, de-stress maybe at the end of a long day. There are plenty of other activities though, and many of you may do things like puzzles, board games, learning new skills, any creative pursuits like art, music. These are all things that are going to be better for you cognitively than you know, turning on the TV perhaps, or being locked to your cell phone screen. And then certainly we know all of these things are important for not only our cognitive ergonomics, but our physical ergonomics, like exercise, but outside of that, mindfulness, meditation, socializing, and one thing we could probably all get better at, which is adequate sleep. So I think that, you know, there are certainly things that we're doing in and out of the hospital that can affect this. I think specifically as surgeons too, we have a lot of things at our disposal and things that we should incorporate, like simulation, mentorship, technical practice, and even video review that really help us to be cognitively ready for what we're going to encounter in the operating room, which is kind of what I deem some of our higher stress settings. So how can you set up your OR for success? I think the ideal cognitive ergonomics involves clear communication with your entire team. And this is anesthesia included, your circulator, your scrub, anyone who's scrubbing in with you, anyone who's going to be present in the room, your reps, whatever, whoever is there. A lot of expectation setting at the beginning of the case, outlining equipment needs, and ensuring that you have closed loop communication. You shouldn't be questioning whether someone heard you while you're operating and having to repeat yourself multiple times. You know, make sure that you're getting some feedback, especially if it's a tenuous situation, that someone is going to get, you know, the clip applier that you just asked for. So that's really important. And you are being looked at as sort of the leader in the operating room to set expectations, I think, when it comes to communication. We've already touched on this, but micro breaks, they've been proven time and time again to work not only for physical ergonomics, but also for cognitive ergonomics. So there's been, you know, lots of different ways to do this. Every 30 to 45 minutes, doing, you know, 60 to 90 seconds. That may seem a little bit long to you, but this could be, you know, a way to improve your performance. It can also interrupt sort of the downward spiral of negative emotions. So if you find yourself getting, you know, really sort of worked up based off of, you know, a complication or something that was said or done, this may be a way to just kind of break away mentally for a second and come back fresh and sort of break away from any sort of negative feelings in the room. Because again, I think we've all been there when someone has sort of set the tone for a room, and this could be a good way to sort of reset that. I talked about planning for your toughest moment, and this is something I talk to the residents about constantly, but you know, minimizing distractions, especially around whatever is going to be a critical moment in the case. You can definitely voice this ahead of time. I think one thing that I've, you know, seen people do is make sure that staff don't take breaks during certain times. Just, you know, and voice that, hey, you know, when we're doing the anastomosis, if we could just have all the staff, you know, stay in so that when we finish that, we can, move on and you can take a break then. Making sure the circulator's in the room, during that, critical time, the anesthesia is aware that this is critical, lower the music in the room, sort of set yourself up for success and plan for that tough moment in the case. And this also brings in what is talked about with pilots with the sterile cockpit protocol, where there's really no non-essential chatter or interruptions happening during a critical moment if everyone's focused there. And then I talk about measure twice, cut once. We've all heard this in some other aspect, but it's how I remind myself to take a short pause before a critical step, to check the anatomy, to ensure I have the appropriate tools in the room, and then to familiarize myself with my backup, my bailout, what's my backup plan, and just to make sure that really I am ready for whatever is going to happen next, if that's a critical moment in the case. I think outside the OR, there are plenty of tasks too. That you're juggling, and it's important to understand kind of what is intrinsic to our jobs as surgeons. We certainly can't exclude ourselves from being interrupted all the time, especially when there's a sick patient or an urgent matter. Some of this is just the nature of our career, and that happens in the operating room too, but I try to remind myself just of the things that I can and can't control, and some that are just intrinsic to the nature of being a surgeon. But there certainly are things, especially in clinic, with building time with your staff to minimize disruptions. This can include some boundary setting where you have an open closed door policy in the clinic or in your office. I found by showing up a few minutes early and answering questions before clinic about patients with my nurses and APPs that this has reduced how much I was interrupted during clinic, where I'm really trying to focus on keeping clinic on time, addressing the patients that I'm seeing in clinic, and not necessarily the ones who have been sending messages all week, and that's kind of when I'm being bombarded with that. So trying to set up little touch points with your team so that they're not necessarily interrupting you when you're doing something else that deserves your attention. I think it's important to understand and evolve your processes, and both how you triage patients, and hopefully to improve the efficiency of your team. This in the long run is going to take tasks off your plate, and again allow you to focus on the things that you need to focus on. Hopefully this also reduces splitting your attention, and I make it a point, anyone who is new to my team, for them to know my communication preferences, whether that's Epic or email, and sort of how I communicate, so that there's no anything being lost in transit there. And they know exactly kind of when I want to hear from them, what I want to hear from them, so that I am hopefully, building efficient teams, and only hearing about the things that really need my attention. I think it's important also with this to automate and have some algorithms to minimize, how much your day is disrupted by the same question over and over again. And then we can't talk about this without talking about the electronic medical record. But this is, what a lot of our day is reliant on, and how we receive much of our patient data. So customizing this as much as possible to show you only the data that you're interested in, that really helps our cognition to focus on the things that's important, and also template the processes that reduce the redundancy in your communication there. So wrapping up, these would be my sort of take-home points from the aspect of cognitive ergonomics. Tying in that cognitive ergonomics is just as critical as your physical ergonomics. You can really structure what can be your most stressful environment to protect your attention. So, be the leader in your operating room and really set the tone for both physical and cognitive ergonomics to be optimal. And then find some cognitive training tool or several to reduce your errors and burnout, and hopefully improve your performance. Thanks for all of your attention.
That was awesome. I certainly learned some tips and some things that have been on my to-do list for a long time that I need to do to streamline my own life. So thanks, Mary Kate. Really appreciate it. Our next speaker is Dr. Tejirian, who has really been a pioneer in the whole area of surgeon wellness. And she has a story that I think has affected a lot of us. So I'm very glad to introduce her to speak about the importance of prehab and minimizing injury and increasing your career longevity. And just to put a plug out for the residents who are watching this, that surgical career is a marathon, not a sprint, and the things you do now can really pay off when you get to to be in your 50s like me. So thanks.
Oh, sorry about that. 1 second. Can you guys hear me okay?
Yep, we can hear you. We're seeing the your slides as well.
Okay. Sorry, I was giving a talk with I was giving a talk that needed to be translated to a different language, so I have it on translation mode.
Oh.
So I'm trying to figure out how to unshare that right now so that you guys don't see the translation mode. And of course, I forgot what I did for my own translation mode. Sorry. This is how you know I'm the oldest speaker, is because I cannot figure out how to undo my. Maybe you can ask a question for a minute.
Sure. If you're working on that, or
here we go. Okay.
There you go. You got it.
Okay. Thank you. And sure. Okay. Good now?
Yep, looks perfect.
All right. Thank you guys for this opportunity and for letting me speak on this topic. This topic is very important to me. And so let's get into it. The people in the audience, and thank you for hanging on since I'm the last speaker. You guys, I'm sure all of you remember your first day of internship, but I remember my first day of internship too, because I was so excited to finally be a doctor, call myself a doctor, start my surgical training, spend some time in the operating room. I mean, I was really even excited to carry the pager. And I remember part of what I started learning from the first day of surgery was that as a surgeon, we are not allowed to be tired. We're not allowed to be sick. We're not allowed to be in pain. You can't be sad. You can't be happy. You sort of just have to be like this superhuman person, because as surgeons, that's what we are. We are able to do more. We don't need sleep. And we just go, go, go. And I totally bought into this. I believed it, that I was going to be this kind of superhero, superhuman person, and be able to just take everything as it comes. And I did that, and I started to build my career. I really got into abdominal wall reconstruction, hernia repair, and so on. And things were going pretty good until they weren't, because in July of 2019, this was my MRI. I didn't have an accident, nothing specific happened, but I had this terrible C-spine disc herniation, and I required a C5/6 disc replacement. You know, I had the surgery. The surgery was fine. I was happy when I woke up. Vascular surgery did not have to be consulted intra-op. So I thought things were okay. But during rehab, I noticed something was wrong. And my arm, my right arm, my dominant arm was not okay. It was weak. It was not acting normally. And I kept complaining about it, saying something is off. And, you know, rehab was just pushing me. You need to just, you know, lift weights, lift weights, lift weights. And I was like, okay. And I just kept doing it. And my arm was getting worse. And now I got this pain, and I had this I developed this pain actually doing physical therapy and rehab. And it took about 7-8 months for me to finally get this correct diagnosis of a nerve root injury. But at this point, my arm was going to be permanently weak. So March 2020, I find out that I can no longer operate. My dominant arm is going to be permanently weak for the rest of my life, and COVID shutdown happened. So things were not good. Things were, and I had also developed this pain, so which was taking over my life. Things were bad. I had a lot of time to reflect, and I was like, we're not, what is this? We're not superhuman. We're not like these superheroes. And I remembered myself as an intern and how I thought of myself as an intern, but then I looked in the mirror and I realized that something was terribly wrong. Something bad had gone on throughout the years when I was in practice. And I had time to reflect, and I thought, well, if we're not superhuman, what are we? And I realized that as surgeons, we're really more like athletes more than superheroes or anything else. And I started looking into this, and that's when I wrote this article that Harry talked about, which was published in General Surgery News. And what was interesting to me was all these surgeons that started reaching out to me, surgeons I knew, surgeons I didn't know, telling me about all their physical problems that they were having from operating. And I realized, wow, this problem is like way bigger than I thought. And we need to talk about this and do something about this. So let's today look at the essential jobs of athletes and compare them to surgeons. Because we know that as athletes, they need to do 4 things, right? They train in order to do the main part that we see, which is competing or playing their sport. And then they do rest and recovery. And I think when we look at this, we know that as surgeons, we only do one of the 4 things, right? We're not focusing on anything else except working and operating and operating. So this is where the problem comes into play, is that no one ever talks about the other 4 aspects of our job that we need to do, because we are in a very physical and physically demanding job. So let's talk about training. And we already talked about part of training, right? We talked about prevention and we talked about ergonomics, and a lot of good speakers spoke to us about it. And I just want to do a shout out also to utilize everything that is available to you to maximize your ergonomics. This is super important. But the problem is that there's no one to help us with ergonomics. We're not all lucky to have an attending who's a trained ergonomist with a master's, level degree of training in this. But hospitals don't realize this, but Amazon realizes this. Amazon hires injury prevention specialists so that their workforce doesn't hurt themselves. So if Amazon really appreciates their workforces need to be physically healthy, why don't our hospitals, why don't our departments realize this? So I think this is the first part of the culture change I want to talk about, which is telling administrators, you know what, we don't need these pizza parties. No one needs these carbs. What we need is real change and something that's really going to make a difference in our health and in our career longevity. But I think ergonomics is great, but it's not enough. And it's not enough because standardization is not possible. Our ORs are not individualized. Each operation is different. And oftentimes when we're operating, we're worried about the patient. We're in the zone. We're not thinking about what position is my back in, what position is my neck in. So I think that's why it's limited as far as how it can help us with our career longevity. So let's talk about the next part of training. And this part is the part that I think is super important and we don't talk about. Again, let's look at athletes. So there's typically 2 types of athletes. There's endurance athletes like runners and cyclists, and then there's power athletes like weightlifters. But guess what? As surgeons, we're both. We have to do both endurance work and we have to do power work. And we don't get to retire at the age of 25 or 28 like athletes do. We need to keep this going for the rest of our lives. So this makes it even harder for us to train than it does for athletes. So let's look at the first part, which is endurance training. So and VO2 max is luckily getting a lot of social media attention these days, but I think it's important that we discuss it for ourselves too. And VO2 max is the maximum amount of oxygen that our body can consume during intense or maximal exercise. Why do we care about VO2 max? Well, it's a really important predictor of what we can do as we age. It's one of the best predictors of overall health and longevity. And without doing anything, it's going to decrease every year when you're over the age of 30. So unless you're an elite athlete in your 20s, if you don't train your body to increase its VO2 max, you will not be able to comfortably climb a set of stairs when you're 75. And at the end of the day, you not only want to train your endurance for your career, but you want to train it for when you're not working, right? When you decide you want retirement, you don't want to be disabled and unable to do everything that you want to do after that point. So this is very important, and we can train for increasing VO2 max, and that's with training of cardio. And I know cardio sometimes gets a bad rap on social media, but it is so important, and there's so many different ways of improving your VO2 max, including high intensity interval training and something called 4x4 training, which is not the same as the 4x4 that you can get it in and out. So please don't confuse those two. But this is really important to put into our weekly training routine. But cardio is not enough. And Harry talked about this a little bit, which is the importance of stability and strength training. This is very important too. Saying something like lift heavy weights, I don't think is a helpful enough advice. And it doesn't help us develop a plan. And that's because as surgeons, we need to do something called neuromuscular re-education. This is training the large muscle groups of our body to take the force and offset it from the smaller muscle groups. So we can use the power that is in our core to offset the power that is needed in our necks, shoulders, and backs and arms, so that we don't hurt ourselves with those areas. And instead, we use the power in our core. This works, and I'm going to tell you how it works. I train in neuromuscular re-education every day, and I've been doing it for many years. And it is the only way that I could function and do activities of daily living, because my arm is not okay. My arm will never be okay. And if I don't use the power in my core, I cannot do activities. But again, this is training that we need to do outside of the operating room, so that when you're actually doing the activity, you don't have to think about it and take up cognitive space of how you're going to use the core to do that. So when we talk about core, the first thing is core stability. With core stability, it's these four muscles that we're talking about: the diaphragm, the transversus. Well, don't forget about the pelvic floor, right? While I'm talking to you guys right now, let's all do Kegel. I'm doing one too. We can all do this Kegel. And then think about this multifidus muscle that I didn't learn about when I was in medical school. And I would love to know if any of you guys have ever heard about this, but apparently it's very important. So first we need to talk about getting our core stable. Okay, relax your pelvic floor. And then let's talk about the next part, which is the core strength. And then this is what people normally think of as core, but it's really 360 degrees, and it's getting this strong enough so that it could offset the work of your neck, back, shoulders, and arms. So again, if you guys don't know where to start, most of us are not athletes or trained in any kind of physical activity. Right after my article, my occupational therapist who helped me, and honestly, he's one of the reasons why I can function more normally as a human being now. He wrote this article, and there's a lot of helpful exercises and information in here as well. Let's talk about the next part of our job, which is to operate. And we touched on this, right? Study after study after study shows that operating hurts. And we know that our necks and our backs hurt, and it doesn't matter what kind of surgeon you are. But what we really need to do is accept the fact that operating hurts and stop pretending like it doesn't, because it really does. And that's one of the things we've already talked about, which are the micro breaks to help. But let's move on. Because we know operating hurts, we need to rest afterwards. Resting is okay. It is not for the weak. This is a slide that I got from an athletic trainer. He gives this to all of his athletes. And look at high quality sleep, adequate nutrition, adequate hydration. Most surgeons are thinking about none of this every day, but this is so important that we think about this for our body. Along with rest comes recovery, right? Because our body is a whole. One part of the body hurts, then the rest of the body goes off balance, and then you're in complete physical pain. And over time, it just gets worn out, and then you end up needing surgery or some sort of life-limiting injury because of this. And let me tell you, there are a ton of recovery therapies that are available to you. So many of these are things that I had never heard of. And I tried almost every single thing because I had to figure out a way out of the mess after all the problems that I had. And I have to tell you, some of them sound insane, but they work amazingly well. Like for me, this Rolfing or structural integration, which is whole body fascial manipulation. I mean, as a hernia surgeon, fascia is near and dear to my heart. And to think that, they can do whole body fascial manipulation. Many years ago, this would have been like the stupidest thing I'd ever heard. But right now, if I don't get Rolfing treatments, I can't function. So what I'm saying is keep an open mind and try these recovery therapies and see what works for you so that you don't have chronic problems over your career longevity. The other thing that we've done is incorporated surgeon wellness centers into surgery conferences, meaning that you get to go to a conference, and instead of having to wake up at 6 a.m. for a 5K run, which I think is not a nice thing to do during a conference, you get to take part of the same day. Instead of going to a lecture that maybe doesn't interest you, you go and you get a physical therapy treatment, acupuncture, massage, all the different things that we have available. So I think this is important that we know that when we're taking the time to go learn how to take better care of our patients, we need to remember that we need to take care of ourselves as well. But how do we really do this? Honestly, we need to hire professionals to do this. The experts that have this kind of training are trained for years to do this. And this, thought of a surgeon, go figure it out yourself, I think that should be a thing of the past. Because at the end of the day, no one expects athletes to physically train themselves or to rehab themselves. High school and college level athletes get like a team of professionals to keep them physically healthy. Why don't we have that available to us as surgeons? After all, I think what we do is pretty important. And I'm going to say a little more important than playing sports, honestly. But that probably might be true for some big sports fans. But it's crazy that we don't realize that we need a team of experts to help us stay physically healthy. So I looked into this and I started to see our training and rehab for surgeons a tax deductible expense. It turns out that it's really not a tax deductible expense. So I wrote to the American College of Surgeons and I asked their political action committee to look into this. Like, is this something you can help surgeons with? Because after all, Medicare reimbursements and stuff, those things are difficult hurdles, but maybe we can do this so that we can show our surgeons that we care for them. They answered me back. And really, they talked about it to see if there is. And their answer was, while physical fitness is important for surgeons, there isn't a direct correlation as there is for professional athletes. Really? Like, how much of a correlation do we need? I think that there is no doubt in the mind of every single surgeon out there that we need our bodies to function normally and function well so that we have career longevity. The fact that our largest and supposedly most important surgical organization is not taking this seriously and backing surgeons, I think is a huge problem. And I just want to speak out about it. And what I found even worse was, hey, guess what, guys? We offer you guys a discount at gyms. So go figure it out yourself. This is not okay. I'm not okay with this. None of us should be okay with this kind of response, because we deserve better. This is how we need to take care of ourselves. And if our leaders do not believe that we deserve this, then how can we make the community at large believe this? So I implore everyone here to please Start to change the way that you think about your job as a surgeon and to tell everybody my physical health matters. I need to take care of myself. I deserve better. I do not want to get sick. And tell your leaders as much as possible as well, because we need to change this culture. A quick few seconds to talk about protecting your most important investment, which is you, because I think most people listening here are in training. And remember to buy your disability insurance early. Buy it when you're young. I know you don't have much money right now, but I am telling you, you don't know what's going to happen to you in the future. And you don't want to get caught not being able to work anymore and not having the financial means to be able to take care of yourself. Having a disability is a very expensive thing. So buy it early, make sure it's specialty specific, and be very careful about this. So what can we all do starting tomorrow to incorporate this into our lives? First of all, we need to prioritize rest and recovery, right? We need to say that it is okay for us to rest. It is okay for our body to have recovery time. And this is acceptable and is not a sign of weakness. And the next thing we need to do is put in the training time, the time to train our bodies, just like clinic is scheduled, just like OR is scheduled. I know it's harder for you when you're a resident to do this, but the good news is that even doing a few minutes of exercise multiple times a day is equivalent. Studies have shown that it's equivalent to doing like a full 30-minute session of exercise. So if you can skip unproductive meetings, skip it. If you have a Zoom, like right now, you guys could be doing some planks, right? You don't have to be on camera, because consistency is key. This is super important. It needs to be on our schedule, just like it is for athletes, and no one should be able to take that time away from us. And in case you forget, I decided to make a music video called Surgeon Wellness. It's set to the Village People YMCA, and I made this before YMCA became popular recently, but hopefully this will help you remember to take even a few minutes out of the day when anesthesia is delaying you, right? Don't be angry. Use that time instead to take care of yourself. So I'm going to play that video now.
It's not playing the audio, unfortunately.
Oh, hang on.
You may have to, when you share your screen, you may have to share the audio.
Working now? Is that working?
The video is playing, but not the audio. You might have to stop sharing and then hit share, and there's like an advanced thing in share that allows you to share the audio with it. Or we can all just sing YMCA while we're watching it.
Or I have to call one of my kids in here and have them do it.
No, we can do it. We're all willing to sing for you, Talar.
No, hang on. I'm gonna play this. So tell me what I need to do again to play it.
When you hit share,
Yeah.
instead of share, there's a button that says advanced, and you have to hit, or actually, sorry, under share options, there's a button that says share sound. You just have to click share sound.
Hang on. Why don't you guys do some Q&A, and I'm gonna get one of my kids in here, and then I'm gonna
Awesome.
Hang on 1 second.
Well, we can start our panel Q&A discussion while Talar's getting that up. And I will just echo her comments about disability insurance. I've had 2 periods of time where I've had to take time off of work for ergonomic injuries, and another time where I had to take off time off of work because of actually cancer treatment. So never would have anticipated any of those things when I was a resident. So I'm very glad to have that insurance.
Any additional questions from the audience, please type it in the chat or the Q&A so we can ask it from our panelists. And thank you everyone for such great talks this evening, and also to all of our attendees.
I'll throw a question out there to the panelists. A lot of our audience are residents, and I think residents oftentimes don't feel empowered to ask for what they need or to take some of these interventions in the operating room. So any advice for the residents about how they can advocate for themselves?
So I'll maybe chime in. As a former program director, a lot of our ergonomics initiatives were actually brought to us by a resident. I mean, there was a period when everybody was focusing on wellness activities and events, and it started with doing a little bit of a survey in the operating rooms from medical students and residents, observing people doing surgery and saying, hey, people were in non-ergonomic positions for extended periods of time. And they said, it doesn't matter if it was ENT, urology, general surgery, OBGYN, that we found that it was an issue. They said the only outlier was when they came to observe my room. And again, that's a different story. But it started with the residents, and they came to me as the PD, and I was like, what, this is an important thing. So you do have to find an advocate, and kind of some of that small talk they have on the side. Hey, like, what are you doing this weekend? Were you chatting about how people are spending their times doing activities. You'll be surprised how many people are like, what? Oh, it was such a long day operating yesterday, and my neck hurts. I really don't want to be operating again tomorrow. Use those little clips and say, well, maybe we should be doing something a little bit different. And I heard that, I saw this webinar, there was this thing that, people are doing to try to mitigate that. So like, take those little sort of impromptu opportunities and really try to take advantage of it. Because if people are not setting up their rooms properly, I think every trainee and probably every attending out there is experiencing those difficulties. Again, oh, we were doing this long case, great case. However, man, at the end of the day, I needed a massage, or I just needed to, get into a hot tub. Well, why was that? Are there things that you could have done to make things different? So I'm hoping that the training environment is a bit improved since, say, when some of us were trainees, but take those little sort of opportunities when they come up to really kind of bring up the topic.
Thanks for that, Ed. I think Deb and then Mary Kate also both had something to say, and then we'll go to Talar's video after that.
Yeah, I think as residents, you have a certain amount of leeway with the nurses in the operating room that attendings may not have. So as long as you're respectful and introducing yourself and befriending them and talking about possible ideas you have and how you'd like to set up the mats and looking at the specific instruments. I guess they're locking instruments. I happen to like locking instruments better, or the inline instruments. And, getting to know them, being vocal with them first. You might see things coming your way.
Thanks, Deb.
I really like to encourage the residents to set up their own screens before they scrub in, so that they can go ahead and take ownership of where that screen is, go ahead and get their steps out, their mats out. And while that's, on them, then they have everything that they need. And so I think, between, advocating for yourself, whether that's, sort of non-verbal things like getting your own ergonomic equipment, or saying something in the middle of a case, hey, my shoulder's really hurting. Can we, lower the table some? And then also, we touched on this too, but building a culture, right? So when I walk into another person's OR and I see the resident with their head like this, I love to move their screen and sort of make it a point to say, oh man, you look really uncomfortable. And these are all things that I learned in training. And so it's a pass it on thing. If you start setting that culture, the residents start bringing up to me like, hey, my hands really hurt after that case the other day. Can you show me what I can do better during this case? And it'll be a chain reaction.
But I also think it's important that we as like attendings and senior surgeons, when we talk about this, we tell everyone that it is not the job of surgeons to figure out what is the right ergonomics for them. Someone needs to come in and teach them what the right ergonomics are. We're not so lucky to have an attending who is trained in this, right? There was no one to teach me, no one. And how are you supposed to know when you're operating what your correct ergonomics is? So I think one of the messages that I want to encourage everyone who's interested in ergonomics to spread is the fact that our hospitals and our ORs need to take that responsibility and hire the professionals to come and help the surgeons do this. Like this, the onus should not be on the surgeons. It should be on the hospital system or in the operating room to take care of the surgeons and the whole staff that's there, to have a professional come in and say, this is what you're doing wrong. This is how you need to fix it, because that's what we need. And I don't think that message is out there enough. And I hope that we can all come together and shout that message from the rooftops.
That's great. Thanks everyone for your responses. Now, Talar, I think we are all ready to stretch our hands on
Should I play it
your
now?
video.
Let's see
Yep.
if it's going to work, guys. Let's see if my kid was able to help me. Okay.
Surgeon, health and wellness are key. I said surgeon, we want you healthy. I said surgeon, we think you'll agree. There's no need to be unhappy. Surgeon, strengthen regularly. I said surgeon, we want you pain-free. You can feel good, and we're sure you will find it's a fun and super good time. It's fun to talk about surgeon wellness. It's fun to talk about surgeon wellness. Anesthesia's to blame, but you fixed it again. You can switch to your workout plan. It's fun to talk about surgeon wellness. It's fun to talk about surgeon wellness. You can get yourself strong. You can help yourself heal. You won't believe how good you'll feel. Surgeon wellness. It's fun to talk about surgeon wellness. Anesthesia's to blame, but you fixed it again. You can switch to your workout plan. Surgeon wellness. It's fun to talk about surgeon wellness. Surgeon, surgeon, there's no need for neck pain. Surgeon, surgeon, feel good once again. Surgeon wellness. It's fun to talk about surgeon wellness. Surgeon, surgeon, are you listening to me? Surgeon, surgeon, feel strong and healthy. Surgeon wellness. It's fun to talk about surgeon wellness. Surgeon, surgeon, give the workout a shot. Surgeon, surgeon, your health matters a lot.
That always makes me laugh. That was Shirin Tofai too with you, wasn't it?
Yes, yes, that's she let us use her operating room also, and she acted in it. It was great.
Thanks for sharing that, Talar. Any other questions from our panelists to our panelists or from the audience?
I have a little question slash comment. I like the idea of, let's just get more anti-fatigue mats and whatnot. I recently did a big open case. I don't do open cases very often, but it was like a big fistula takedown. And I found out in my hospital there was only three anti-fatigue mats. And the staff kept calling it princess pad, and it was like, first of all, like let's not call it a princess pad, right? It's called an anti-fatigue mat. But then there was only three, and then when it comes to time to ask for hospitals to like purchase more things, right? Even though it's not very expensive, I think everyone just always tend to have a hard time dealing with administration or trying to get anything new or any more things into the operating room. People might ask like, "Oh, do you have data to support this?" That goes back to the letter, like, Talar got. I was like, okay, there's not a clear association, blah, 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 whatever. So are there like things that like in terms of like OSHA requirements that we can use as like, support, or what, how do we go about that if we meet resistance from, the hospital side in terms of like getting these equipments?
So the interesting thing is OSHA actually doesn't really have much jurisdiction for healthcare industry. So it's more governed by JACO, which actually is focused more on systems and policies. So that's why you don't see OSHA frequently coming into a hospital. I mean, I joke, like, I'm like, violation 29 Code of Federal Regulations right there. Here's another violation right here. That doesn't happen in hospitals. And again, that's not JACO's focus as well. So there really isn't that same level of scrutiny as it is, say, like when I went to the Procter and Gamble facility or the GE aircraft engines. It's like, that's why those places are pristine on these large companies, because they will get cited and fined. That won't happen in our profession. And now maybe things need to change, but at the same time, somehow the healthcare industry is in its own little world when it comes to that sort of thing.
And
Sorry, go ahead.
like there's other things too that we don't talk about, like surgical smoke, right? Surgical smoke is so hazardous and no one is addressing that. And that is putting everyone's health at risk in the operating room. And you know what blows my mind? There was this obsession about paper caps, or you wearing your own caps versus not wearing your own cap. What are we talking about? Why are we wasting time? There's everyone inhaling this like surgical smoke and no one is talking about what's important. So again, I think it is our job to not ignore it, to be like, get me that smoke evacuator. I don't care how like demanding you think I am. Get me my princess pad. I don't care what you call it. Get it to me. Like, I deserve this. And then that's it. So I think if we all decide to do it together, if we all come together, all the surgeons, general surgery, ortho, neurosurgery, if we all come together and say, we need to get this in place for the health of everyone, then that's when things are going to change. But we have to point it out. We can't just be like, oh, okay, I'll change my cap right now. No, this is stupid. Let's talk about what's important. But I think the squeaky wheel gets the grease, right? That's what we need to be here.
It's interesting you bring up surgical smoke. In Washington State, the Washington State Nurses Association made a big effort around surgical smoke, and there's actually a state law that all ORs have to have smoke evacuation. And that is actually a model for what we've done for other things like ergonomics, like getting the anti-fatigue mats. It wasn't actually the surgeons that got them in the operating room, it was our scrub techs. But because we got a coalition of the team, the scrub techs and the surgeons, we were able to get admin to buy in, and now every room has mats. And it's not like they have to go get them from somewhere. They're just there. But it really built the team coming to administration to ask for these things. You sort of have to almost build a business case for it as well. So talking about efficiency, the things like people worry about micro breaks being inefficient because they take time, but actually they improve efficiency by increasing focus. So building that case that all of these things actually help outcomes and help prevent injury is really what it takes.
So one other thing for all the panelists, if you could emphasize one point from your respective talks as a take-home message for our residents and fellows, as we have 5 more minutes left. Can you state that one point that you want fellows to take home, residents and fellows to take home from your respective talks? Let's start with Nisha.
So I think the biggest point is whether you do this on a small or big level, at the end of the day, focusing on your ergonomics, even if you do it just for you, it affects you. It affects your physical life, cognitive life, potentially financial life. So trying to do it just for your health and you as a surgeon is very important, even though it's very hard to do. And I think you got a lot of concrete ideas. So maybe just start with focusing on one so that in the long term, this will really result in a better career and a better, like, hopefully lifestyle.
All right. Don't forget about yourself. Self before others. Ed.
Be proactive about setting up your work environment. If you are the one who's in there, and be cognizant of the other people. So if you recognize, yes, your attending's taller or your student's taller, set it up for them, bring in the steps and say, I'm setting this up for you. And then I'm going to get on the steps to make the environment appropriate, or I'm putting the monitors to help everybody as a whole team.
All right. Self and then others. Make it a team effort. All right. Harry.
Mine is pretty straightforward. So, use the inefficiencies of the hospital system to your advantage, right? Use the free time that you have during the surgery, in between cases, to do your micro breaks and your stretching. It will pay off in the long run.
All right. Make the most of your time before, during, and after. Mary Kate.
I kind of hit a little bit of this, but I think that, cognitive ergonomics is just as important as physical, and trying to keep things as simple as possible for yourself in the operating room so you can maintain your focus.
All right. Maintaining your focus is very important. So ergonomics can play a big part of that. And Talar.
I said it like several times, but I would love to keep saying this every single day. Your health is important. You as a surgeon need to take care of yourself. Do not for 1 minute think that you don't deserve it. And the healthy surgeon is the strong surgeon, and that's what we need to be. Don't do what I did, what we've been taught to do. Take care of yourself, and let's all come together and make sure that everyone knows that surgeons deserve better.
Thanks, Talar. And our two other co-moderators, Deb, final thoughts?
Yeah, I want to echo what everyone said, and also just to be vocal. If you recognize a need, speak up about it, talk to the reps, talk to other doctors, see what other people do in their operating rooms. This is not an isolated problem. There are new tools coming out.
Excellent. And Andy?
Yeah, and in the words of Ice Cube, you got to check yourself before you wreck yourself. So take care of yourself. It's a long career, and the more you invest into it, the longer that career can last.
And with that, we end tonight's webinar on ergonomics. And please, for those who joined, please join the next webinar for SAGES. It's going to be December 9th. It's going to be the General Surgery Review Part 1, chaired by Ivy Haskins and Michael Wad. And so with that, thank you, everyone, and have a good evening.
Thanks so much.